HealthEd is Australia's leading provider of quality clinical education for doctors and other healthcare professionals. This episode has been made available on Spotify and Apple Podcasts. For free access to the full library of podcasts and to claim CPD for listening, visit healthed.com.au or download the HealthEd app.
Hello, I'm Terry Foran. My guest today is Professor Creswell Eastman. We're going to be talking about an area of clinical practice he's passionate about, namely iodine deficiency and thyroid disease in pregnancy. Professor Eastman is a clinical professor of medicine at the University of Sydney and a consultant physician in endocrinology and public health. He's also the current chairman of the Australian Centre for Control of Iodine Deficiency Disorders. He's led major projects into thyroid disease and iodine deficiency disorders in China, Tibet, Thailand, Laos, Cambodia, Vietnam, Indonesia, Australia, and several of the Pacific Islands. Prof. Eastman has been a consultant on iodine deficiency disorders to the WHO, UNICEF, and the World Bank, and led the National Iodine Nutrition Study conducted on Australian children in 2003 and 2004. I suspect, in fact, there's very little about thyroid disease and iodine deficiency that Professor Eastman has not contributed to. So it'll be great to share in that wisdom today. Hello, Chris, and welcome to today's HealthEd Women's and Children's Health Podcast.
Hello, Terry, and thanks for inviting me to join you.
Chris, I've just run through your bio with our listeners, and your passion for the effective diagnosis and management of thyroid disease in pregnancy is obvious. Can you tell us a little bit about what sparked that interest initially?
Well, Terry, as we've discussed in previous podcasts, I've had a major interest in thyroid disorders within endocrinology, having originally set up some of the current assays that we take for granted for measuring thyroid hormones.
Mm-hmm.
So once you start developing these means of measuring and testing and analysing clinical situations through biochemical analysis, then it leads from one thing to another, and certainly led me into the thyroid area. So I've had a particular interest in thyroid disorders, and particularly relating to the development of the fetus. And so that takes in pregnancy. And as part of what I do, I've sat on various expert guideline committees for the American Endocrine Society, the NHMRC, and working out best means of looking after, diagnosing and managing thyroid disorders in pregnancy.
Chris, can I take the opportunity at this point of recommending our previous podcast to our listeners? It was a really great overview of the importance of adequate iodine in pregnancy. So it is good to have the opportunity in this podcast to zero in a little bit more on management. So first up, why should we be aiming for a TSH under 2.5 in patients who have no known thyroid disease and are trying to conceive?
Terry, before I start, I should say that some of these comments I'm going to make remain controversial. In other words, there's no universal agreement on some of these issues because of lack of overall incontrovertible evidence. So I'll do my best to say where the evidence is and where it's a matter of consensus. But again, I might return to what we were talking about with iodine in pregnancy, that to ensure that maternal thyroid function must really be perfect to ensure development of the brain, of the fetus, and also for maintenance of a normal pregnancy. And if thyroid function goes wrong, particularly become underactive during pregnancy, then there will be consequences, particularly with in the pregnancy with regard to miscarriage, preeclampsia, hypertension, small for gestational age, early premature labour, and of course, all of those things were a threat to the viability of the fetus. And finally, we know that if the mother becomes seriously, overtly hypothyroid in pregnancy, then her child will suffer quite considerable intellectual disability. So it's critical that thyroid function in pregnancy is kept normal within an optimal range for the 3 trimesters. So it brings us back to what are the factors that affect or may disturb thyroid function in pregnancy. Well, the first one we talked about is iodine deficiency, because the thyroid needs enough iodine to make the appropriate amounts of thyroid hormone. And during pregnancy, the thyroid undergoes a stress test. It's the only time, in a sense, in lifetime that the thyroid is stressed, because pregnancy hormones being chorionic gonadotrophin, which looks like and acts like thyroid stimulating hormone, acts on the thyroid to make it pick up more iodine and make more thyroid hormone, and it turns off the pituitary TSH. So you have a situation where the pregnancy in the early part of the first, second trimester of pregnancy, where the pregnancy in a sense has taken over the thyroid to produce more thyroid hormone. So if the thyroid is lacking iodine or it's damaged, it can't respond to that need to make more thyroid hormone. And we know that, again, autoimmune thyroid disease is very common in our community. It's common in many different, pretty well all ethnic groups that we've looked at in Australia. And up to 10% of women in our community may have underlying autoimmune thyroid disease. Now, that may not be obvious in the non-pregnant state, but once the thyroid is stressed, it has to produce more thyroid hormone. It may not be able to meet those requirements. And as a consequence, you're going to get obstetric and fetal neonatal complications. So it's critical that the TSH, which we use as a marker of thyroid function, the best marker of thyroid function, that we keep that within the normal reference range. Now, this is where we get into controversy as to what is the reference range. Well, the reference range for TSH is different during pregnancy than the non-pregnant state. So you can't use the standard TSH level reference range that you get from your lab for non-pregnant state. The accredited labs, and they're all pretty well doing the right thing now, and producing reference ranges that are trimester specific, and they're derived from local populations, and they're by and large suitable, for the general practitioner or whatever to use those reference ranges. Now, this figure of TSH of 2.5 has been the magical figure that was agreed upon by an expert guidelines committee of the American Endocrine Society, supported by many other expert groups, that you should keep your TSH level below 2.5. You shouldn't, if you're taking thyroxine, not take so much that you suppress it where it's unmeasurable. But TSH of 2.5 is the cutoff point. It's the highest level that you should have during pregnancy. So we recommend that women who have a TSH level above 2.5, they be considered for thyroxine treatment. Now, when I say we recommend that recommendation is agreed to by multiple different expert bodies throughout the world, but not all. The American College of ONG and the Royal Australian and New Zealand College of ONG, they don't agree with that. They say, well, there's not enough evidence to say that a level of TSH over 2.5, say less than 10, causes any significant damage. And they base that argument upon two randomized controlled trials that took women and, they were divided into two groups, the treated and non-treated groups. And these two trials didn't find any significant difference in terms of outcome. Now, while they look impressive and they were both published in the New England Journal of Medicine, my view and the view of many experts that know as much or more about this than I do would argue that those trials were flawed in the sense that treatment was started in the second trimester and it was probably too late. They'd missed out on a lot of these adverse effects that occurred as a consequence of lack of thyroid hormone in the first trimester. So it remains controversial. So what do you do? Well, in my view, if the TSH level is 2.5 and that woman has positive thyroid autoantibodies, then she should be treated. Certainly over a level of 4 and positive thyroid antibodies, I think no one much would disagree that about treatment. You should give them thyroxine. I mean, I don't quite understand why you wouldn't. I mean, there is an argument saying, well, look, it's unnecessary, it might do some harm, it's costly, and so on. I mean, I think they're rather poor arguments. I mean, I wouldn't deny a woman that. I would certainly explain to a woman that, this remains at these low levels. It remains controversial, but, what she most wants is to protect her baby, protect her pregnancy and to protect the baby and give that baby the best start. Now, we know that giving low-dose thyroxine is safe. Again, Norman Blumenthal and I did a large study, over 1,000 women in Western Sydney, and this has been peer-reviewed, published, and we showed no significant ill effects from the treatment of these women with thyroxine. So yes, there is a cost to the government through the PBS, but it's a very small cost. But the gain is extraordinary if you're going to prevent these adverse effects during pregnancy, and if you're going to prevent damage to the brain of the newborn. So my argument is fairly simple, that why wouldn't you treat them rather than you don't have enough reason to? As I'm saying to you, that's controversial, but I think the majority of endocrinologists throughout the world would have the same view as what I've got in terms of diagnosing and treating these women.
This episode is one of hundreds of informative and free clinical podcasts from Health Ed. Access the entire library through the Health Ed app for healthcare professionals, which you can download today from the App Store.
Chris, how often should thyroid function be measured in pregnancy if a patient is taking thyroxine?
Well, the first test should be done within 6 weeks of, certainly soon after the first missed period, because the thyroid hormone levels change dramatically, as I said, due to HCG within the first few weeks. So as the HCG rises, the thyroid has to make more thyroxine to maintain the pregnancy and to pass it across then to the fetus. So the first test should be done 6 weeks, and then it should be, if you're on thyroxine, the woman has been on thyroxine before she was pregnant or commenced during pregnancy, then I would repeat it every 6 weeks, certainly for the first 2 trimesters. Things settle down in the last trimester and it remains fairly stable. So I think once you get, beyond 22, 24 weeks, it's fairly stable. You may test once or so in the last trimester, but there's no clear-cut guidelines as to when you should do that. But certainly up to, the end of the second trimester, you should be testing it every 4 to 6 weeks.
Chris, that interval's a little shorter than the one that's usually recommended. Does that affect the accuracy of the results in any way that we get back from the lab?
No, not really. I think 2 things. One is which is a drum I beat a little bit, that if you're going to get your thyroid function tested, your TSH and free T4 level, do not take your tablets that morning. Women or patients on thyroxine are recommended to take their medication first thing in the morning on an empty stomach. Now, if you do that and you turn up at your pathology laboratory or centre to get your blood test done, you may turn up at 8 or 9 or 10 o'clock in the morning. Then if you've taken your thyroxine, you get a blip in terms of the level in the blood. So you should not take your medication that morning before you have the blood test. You should take it afterwards. That's the first thing. The second thing is we know it takes 4 to 6 weeks for changes in thyroxine level and to have an effect on TSH and for that to equilibrate. So to be safe, we usually recommend 6 weeks in the non-pregnant state. But, that's just taking a safety provision and also taking a position where you're not overdoing thyroid function tests. But in pregnancy, you don't have much time. You can't afford to get it wrong. So I think certainly 4 to 6 weeks is perfectly reasonable and correct during pregnancy to be retesting and monitoring thyroid function.
Chris, you've already mentioned autoimmune thyroid diseases. What are the commonest kinds of autoimmune thyroid diseases we might see during pregnancy?
Well, the commonest one is Hashimoto's. Graves' disease tends to ameliorate and get a lot better during pregnancy. So that's unusual. I think a woman with Graves' disease during pregnancy should be managed by an endocrinologist. Mostly it ameliorates, but you have to be careful that before the baby is born, that the thyroid stimulating antibodies that are driving the thyroid are not too high, because they can cross the placenta and the baby can have neonatal thyrotoxicosis. Now that's unusual. It's not rare, but it's pretty unusual. So that should be managed by an expert group. On the other hand, as I said, Hashimoto's thyroiditis is very common in our community. Our own figures suggest up to around 10%, certainly in Sydney, are women with positive thyroid autoantibodies. Now, if you look at the ABS figures of around 300,000 babies are born in Australia each year, then you're looking at up to 30,000. Our own data suggests that somewhere between 5,000 and 15,000 women, who extrapolate throughout Australia, would suffer from subclinical hypothyroidism. And our other figure that we've derived, again, if it's credible and applicable throughout the whole country, then around about 1,200 women will get overt hypothyroidism in Australia during pregnancy. Now, those figures are a bit scary. I think that the numbers are really quite high. And to me, it confirms the reason that we should be looking for this. So if a woman has a family history of autoimmune thyroid disease or other autoimmune disorders within the family, such as type 1 diabetes or pernicious anemia or lupus or even celiac disease, then I think when her thyroid function is checked for the first time, when you do antenatal screening, then she should ask for thyroid autoantibodies to be done. Because if she has thyroid autoantibodies, she's at risk of becoming hypothyroid. So the risk is reasonably high. I mean, I'm surprised at how common this is, as I said, up to 10%. And in some communities, particularly with our Indian communities and some Pacific Island communities, we know that the risk is much higher than that. So these communities, these ethnic groups are at greater risk. So they're the major ones that you'd consider, and there is a considerable risk, as I said.
Chris, I guess a question out of left field: do we see this sort of thyroid disease in postpartum patients as well?
Yeah, we've overlooked that. I think if a woman, for example, has Hashimoto's disease and let's say she gets through a pregnancy, she's been treated with thyroxine, she delivers the baby and everything's fine. She probably doesn't need a thyroxine after that, or in the immediate phase, she will need it next time she's pregnant. But that's the sort of woman who with thyroid antibodies that is risk of postpartum thyroiditis. Now, these women, in my experience, and I think it's true in the literature, that the diagnosis is often overlooked because it can present in various ways. It can present in the classical way of an overactive thyroid occurring somewhere for 6 weeks at least, of anywhere up to 12 months. Firstly as being hyperthyroid, and that may last for several weeks, and then it becomes hypothyroid, which may last for months. Most will recover, but not all, and they may then end up being permanently hypothyroid. Often this is not diagnosed or mistaken, or as baby blues, or the woman's not coping with a baby, or there's problems at home. In other words, various things. She's attributed to various life events or other things happening in the life of the woman, rather than the fact she's got disturbed thyroid function. So it's very important that one thinks of this in a woman in postpartum who's got depression or anxiety, or has got other symptoms such as weight loss or excessive tiredness and so on, to check their thyroid function. If that woman has, and she's known to have thyroid autoantibodies or a history of autoimmune thyroid disease or a family history, then I think it's absolutely critical that thyroid function is checked. If you don't think of it and don't do the testing, you won't diagnose it. It'll be overlooked and she will suffer, for 12 months or more.
Cres, there's a lot to take in. Are there any good resources or websites that you might be able to direct our listeners to if they're grappling with the management of thyroid disease in pregnancy?
Yeah, again, there's a lot of good information on the Australian Thyroid Foundation website. There are multiple good articles on thyroid disorders in pregnancy, thyroid physiology of pregnancy, number one. Number two, I think, again, the best place to go is the textbook on thyroid disorders, which is called thyroidmanager.org, thyroidmanager, all one word, .org. And that covers the whole field of thyroid disorders, and Each of those chapters is available. You can read it for free. Each of those chapters is written by experts in the field, all peer-reviewed and agreed upon by a very expert body that's put together this book. So they're the best, the local Australian Thyroid Foundation website and Thyroid Manager. If you want more details and more technical details, you'll find it there.
Perfect, Cres. I'll be sure to put links to those on our website as well to make it easier for our listeners to get to.
Thank you.
Cres, we're getting pretty close to the end of the podcast, but can I ask you to summarise the most important messages that you'd really like to get out there to our listeners regarding the management of thyroid disease in pregnancy?
Well, I think the most important thing is that thyroid health, it's critical that thyroid health is kept normal throughout pregnancy to preserve and sustain the pregnancy and prevent damage to the fetus. Now, that's the first thing. The second thing is that to ensure that a woman is getting enough iodine before and during pregnancy and takes a supplement. The third thing is that I think all women should have a thyroid function tested when they do their antenatal screening, which is usually soon after first missed period. They should have thyroid function testing. Again, that latter issue is controversial. Not everybody would agree that you should be tested, but I think I've been able to provide, convincing arguments, both orally and written arguments, that why these tests should be performed and why women who have disturbed thyroid function should be treated to do our best to prevent these complications that we know occur during pregnancy and can affect the fetus. Final point is that if there is a history of autoimmune thyroid disease, and that woman that has that history is at risk of developing postpartum thyroiditis. So if she has any illness that is not clear-cut reason for it in the postpartum, particularly if it mimics depression, the blues, anxiety, then look for thyroiditis, postpartum thyroiditis as a cause for that.
As always, Cres, it's been a really great discussion, and I want to thank you so much for sharing your time and expertise with all of us today. You take care.
Thanks very much, Jane.
Thank you for listening. Visit healthed.com.au to create a free account and claim CPD for podcasts like this and access a record of your learning. Subscribe to the show on Spotify or Apple Podcasts for weekly episodes on a range of clinical areas relevant to your ongoing practice.